Good afternoon, everyone, and welcome to another session of COVID-19 Academy. We are celebrating the World Environment Day through a series of panel discussions on pertinent topics, bringing together the thematic of environment and COVID-19. And towards this, today is our second panel discussion. The discussion is on climate change, putting public health first. The panel discussion will discuss and cover themes such as health vulnerability of communities due to climate change, impact of climate change on well-being of human society, and health as a catalyst in just transition and green economy. Today, for this discussion, we have with us eminent panelists. We have with us Professor Amitabh Pandey. He's the Associate Professor for Sociology and Community Development at IIFM. He's a PhD from University of Hyderabad with specialization in common property resources with cultural perspective. His areas of interest, amongst others, include public policy analysis, adaptive management, management of common property resources, sustainable livelihood, community driven development, etc. Next, we have with us Dr. Avinash. Dr. Avinash is the Assistant Director for the National Program for Climate Change and Human Health at National Center for Disease Control, Ministry of Health and Family Welfare, Government of India. He's a public health expert, and his core area of work involves implementation of disease control programs at various levels. Next, we have with us Dr. Harshal Salve from AIMS, New Delhi. He's currently working as a faculty at Center for Community Medicine, AIMS, New Delhi. He did his MBBS from Government Medical College, Nagpur, and completed post-graduation in community medicine at AIMS, New Delhi. Dr. Salve has 8 years of experience as a physician, public health trainer, community-based researcher, and public health professional at AIMS, New Delhi. Next, we have with us Dr. Meena Sehgal. She's an epidemiologist by training and works on environmental issues impacting human health. She leads a team of research professionals working on assessing various environmental compartments for pollutants and health effects. Ms. Sehgal earned her master's in public health in international health in 1996 from Rollins School of Public Health, Emory University, Atlanta, USA. She is from Terry. We have with us Dr. Nitish Dogra from IIHMR, New Delhi. He's the associate professor at IIHMR. He has done his MBBS and MD from University of Delhi. He has a sorry for that. He has a Master of Public Health degree from Johns Hopkins University, United States. Subsequently, he has worked in several coveted institutions, including JHU, INCLEN, and TERI. He had earlier served as assistant professor at IIHMR, Delhi from 2009 to 2014. Last, I would like to introduce our moderator for today, Mr. Manjeet Singh Saluja from WHO India. Manjeet has been working in the area of environment and development since last 18 years. He currently works with WHO country office in India as a technical focal point on environmental health that includes issues of water and sanitation, climate change, air pollution, and its effect on public health. He has been closely coordinating the efforts of WHO country office and the Ministry of Health and Family Welfare and the UN partners to integrate health and develop the health sector capacity on various environmental risks. So before I hand this over to Manjeet, I am going to make a slight request to all our participants. Except our panelists, all participants, please keep your videos switched off. We have Glenda with us, who will be doing a sign language interpretation to make this session more accessible. So I request your cooperation. And with this, I would like to hand over to Manjeet now. Thank you.
Thanks, Valerie. Very good evening to all the panelists and the participants who have kind of joined us for this webinar from various places in the country. And as shared by Valerie, this webinar series is being as a part of the upcoming World Environment Day. And we are trying to touch important issues, environmental issues that have an kind of an impact on health and well-being of not only the humans, but also the planet as well. So the thought
Is Mr. Manjeet audible to anybody? Okay, I think Mr. Manjeet is back. Manjeet, are you there? You'd have to unmute yourself and speak, please.
Yeah. Audible?
Great.
Yes, Manjeet. Now you are.
Yeah. Thank you. So apologies, the technology kind of sometimes does create some moments of this well. So I was talking about planetary health and human health. About the planetary health has been kind of was in kind of captured in the deliberations of the recently conducted 73rd World Health Assembly, and it was kind of said out there that the pandemic is a reminder of the intimate and delicate relationship between people and planet, and any efforts to make our world safer are doomed to fail unless they address the critical interface between the people and pathogens and the existential threat of climate change that is making our earth less habitable. So to address this issue of today on climate change, we have an eminent panelist. I think Valerie has already given the introduction. I need not to say anything more. Just kind of saying that experts would be kind of undermining thoughts today on the issue. So I think not wasting any more time, let me kind of immediately put the first question and set the context to put the first question to Dr. Harshal Salve, who is from All India Institute of Medical Sciences. And Dr. Salve, we would certainly like to kind of hear from you that we all know that climate change is affecting human health in a variety of ways. And since you have been working in this particular August Institute and you kind of know also a clinician and also have been a kind of a researcher in this field. So can you share some examples in which you have seen the patients or even larger populations which are getting affected by the impacts of climate change, both from your research background as well as from your clinical background? So Dr. Salve, please.
Thank you, Dr. Manjeet, for having me here. So before going further, I just want to briefly set a context right here. So we all know climate change is happening because of anthropogenic activities by burning fossil fuels, increased CO2 emissions, and deforestation. So it is manifested in the two forms, basically: rising sea surface temperature, rising sea level, and with the frequent extreme weather conditions. So it has both a direct and indirect impact on the human health. If you really want to see, the major impact is seen through the heat with the rising surface temperature, change in the vector-borne disease pattern, and indirect impact in the form of extreme weather events, which is hampering day-to-day life, the lifestyle, the mental health issues, which is also coming up due to that. And also the important thing, which is talk of a town, particularly in Delhi and across the globe, is air pollution. The climate change, the increased surface temperature also it increase the impact of air pollution on the human health. As far as the evidences from India are concerned, so first going to the heat impact on the human health. So we have done a systematic review that is compiling the evidence of various studies done in India so far to see the temperature, ambient air temperature impact on the human health. So if you see the overall summary of these studies, so risk ratio, when we say the impact, when we say what it impacts, all cause mortality. So you can see almost 1.7 to 2.1 times increase in the all cause mortality has been reported due to the increase in the ambient air temperature. There are also few studies which are reported the cause specific mortality in terms of increasing cardiovascular diseases, increasing the respiratory diseases due to the ambient air pollution. So there are also various studies in particular western part of country from Ahmedabad. So they have also demonstrated that with the spike in the ambient air temperature, there is a spike in all cause mortality. So there is a dose response relationship has also been established. Coming to the second type of disorders, particularly vector-borne diseases. So we all know that India is a tropical country, which is a host of various vector-borne diseases, for example, malaria, dengue, chikungunya. So what is happening due to the rising temperature, and which in turn in the change in humidity, that the distribution pattern of these all vector-borne diseases are changing. Traditionally we learned that the transmission season, that is from June, which we start from June, which lasts till September, where you will going to see the maximum vector-borne diseases. But due to this climate change, you can see the vector-borne diseases early, particularly in February, March. Now in our day-to-day clinical practice, we have started uh, the patients with dengue, malaria started coming. I recently seen the report from SDMC that they have reported a higher number of malaria, dengue, and chikungunya cases in the month of April itself as compared to previous year. So you can see clearly the change in pattern of occurrence of these vector-borne diseases, which is also evident in the clinical practices. Second thing is about you are also seeing there is a scientific evidence that the malaria is also documented in the Himalayan region, the region which was so far, which was sort of devoid of these vector-borne diseases. That this has been reported also from the coastal region of the country. There is also reappearance of the chikungunya, which are all linked to the climate change, as far as the vector-borne diseases are concerned. Coming to the next type of disease is malnutrition. As I said, climate change indirectly affects the agriculture. It affects the agriculture yield. The country like us, where every third child is malnourished or undernourished, so this complicates the problem further. There is an issue of generalized nutrition, and also the issue of specific micronutrients, which both get affected due to climate change. Third impact we are seeing, as I said, the on the chronic diseases, the indirect impact due to the heat. We know that in the routine practices, the most of the disease burden is contributed by the non-communicable diseases. We are seeing both the pandemic of communicable as well as the non-communicable diseases. So the mortality and the morbidity due to cardiovascular diseases, the stroke, is increasing due to the increase in surface temperature. Clear-cut evidence is available internationally, as well as the national evidence is also available. The mental health, again, an important event which is linked to the climate change, particularly to the post extreme weather events, for example, cyclone. In the recent time, we have seen our east coast getting affected with the Amphan cyclone, and now currently we are seeing the Nisarga cyclone, which is affecting the west coast. So the mental health issue, for example, post-traumatic stress disorder, the lifestyle change, it is there. It is attributed to the climate change with the and the extreme weather situation which is happening due to the climate change. Uh, in the response to the as an effect of these extreme weather conditions, you can also see the rise in the cases of diarrheal diseases due to the contamination of drinking water. You see, in the under 5 children in India, the diarrhea is again within the three important causes of mortality. So this in turn impact our neonatal health, our infant health, and other health parameters. Coming to the last point with respect to the air pollution, we all know that air pollution itself has its independent risk factor, documented as an independent risk factor for morbidity. So if you see the daily loss of life is almost in the 103 million due to ambient air pollution in India. The majority of deaths happening due to air pollution is with the non-communicable diseases, cardiovascular diseases, stroke, diabetes mellitus, and the cancer. And excess of more than 7 lakh deaths in India, as per the estimates of World Health Organization, is attributed to lower respiratory infections. And again, the important cause is household air pollution. But the climate change, due to its impact on the temperature, aggravates the impact of air pollution on the human health. So, if you see in totality, the climate change and its impact affects the most of the diseases which is currently prevalent in India, and we are seeing it. For example, in the particularly in the season, when we have a paddy burning season, in the month of November, December, there is a clear-cut pattern of increase in the hospital admissions with respect to the exacerbation of the COPD. It is well documented, particularly in the season where we have a heat waves, which is reported due to excess temperature, there is a clear-cut increase in the non-communicable diseases, for example, stroke. Then other direct manifestation of the heat like dehydration, and all this are reported in the routine healthcare system. So, though there are dearth of the studies, particularly the cause-specific related evidence is linking to the climate change, particularly in India. Thank you.
Thank you, Dr. Salve. I think you very well laid the context, and I think all the aspects which touch the human health when we talk about heat waves, we talk about wash, water sanitation, hygiene, we talk about malnutrition, mental health, non-communicable diseases, cardiovascular, air pollution, vector-borne disease. You have kind of tried to sum up in a few minutes, but very well kind of laid out. I think. And you also very well set the kind of context to the next question when we are, and this I'll kind of want Dr. Amitabh Pandey to come out here, because we know now with this that the effects of climate change are kind of substantial, and there's nobody who's going to kind of skip the impacts of climate change. So it affects everybody in various seasons. So whether it's the rich or the poor, or kind of coming from any strata of the society, it's going to hit that. We may install whatever in our houses, but we need to breathe the air. So air pollution comes in, heat comes in. So, but again, we kind of I would like you to elaborate, especially on the most vulnerable communities. There would be some kind of a differential impact, and please elaborate on the most vulnerable communities, the most vulnerable individuals, as climate change really takes this hold. Who do you worry would be the most affected, and what would be the kind of disproportionate effects of climate change on these vulnerable communities? If you can throw some light on this, Dr. Pandey.
Thank you, Manjeet. Basically, I'm happy to see the panel, mostly doctors and other specialists. I am being the social scientist, and I had that advantage of putting the perspective of community and the society in the debate. So coming to basically the climate change, if you see from two angles, the change is experienced in time interval of 50 years. So one human being may experience a 2 cycle or 1 cycle, that may be there. Second main important factor is the climate variability, which is affecting the community. So that was one aspect I would like to be clear. Variability when we are talking about changing in temperature, what earlier speaker doctor was saying, and that precipitation. They are now becoming erratic and unpredictable, and that's the main factors which is influencing the community. Second, I move to the human diversity in India, especially. If you see the India, if you go by K.S. Singh report, it says 3,500 communities live in India, but you go by the Ministry of Tribal Affairs, there are 622 tribal communities in India. And basically, they are the most vulnerable because the kind of environment they live is degraded forest areas. They are basically living with the natural resources. They are in the mining areas. So we need to be there. If you divide the indigenous communities in India, which has been there, government they divide into two things. One is scheduled tribe, which we come across. Second is the primitive tribal groups. There are 74 such groups. They are very vulnerable. If you can see the 4 of them in Andaman Nicobar, the Onges, the Jarwas, the Sentinelese. If you come to India, in Madhya Pradesh, you have this Baigas, Baharias, Saharias. So classification of communities, basically the tribal community is one parameter where we could see and try to see how the climate change affects them. Second is if we see the agrarian communities. Agrarian communities again have very good caste classification where you start from the landowning caste, service caste. Service caste becomes more vulnerable because to fall back on resources, there is important aspect. So if you try to see how the climate change is impacting them, it's you need to say how the consumption pattern is changing. So there are 4 factors of climate change. One is on consumption. We have becoming consumerism society. So to develop that, we are trying to becoming more produce more industrialization, more mining, and that affects this community. I was working with Coal India, and the displacement which takes place, the most impacted is the tribal communities, which moves from those areas where they have been living itself into distress. And when you are moving them again, you are into a crisis there. So that's one area where you can see the consumerism, the high habit of food, the kind of agriculture production. So that's one area we could see. Second is the land use pattern. So the land use pattern is a very important factor, because for the livelihood, we started increasing the agriculture and reducing the forest cover. So if you try to say 40% of area in India is agrarian now. Forest has reduced to only 24% because of last few decades of development work in forestry. We could see a growth of 2-3%, but still far away from 33%. And if you say around in India, around 180,000 villages live near around forest. So they are basically residents by the tribal communities, the indigenous communities, and their vulnerability is increasing because with the changing scenarios of this. So that's where land use becomes another. A third aspect is the energy use, the kind of energy we are using it, fuel, wood, or for the electricity. Again, we are doing mining, all kind of dams are coming up. The communities living near natural resources, they become distressed and they move out. So this is one kind of things happen. Third is the population dynamics. The population is very important there, because that becomes another factor of reduce. If you see the Jarwas I'm talking about in Andaman Nicobar, they were around 1,000. Now they're reduced to 125. We are losing a whole community in Andaman Nicobar, which has become very vulnerable. And climate may be one of the factors there, which may be affecting them. Secondly, because of other factors. In other places, we could see these things are happening. So basically, these are the factors which are affecting them. And tribal health has become more vulnerable because the impact of climate change, as a doctor was saying, as because of air pollution. So those living around the mining areas, they are affected. If you see this area of Sonbhadra of UP, they have lots of industries, and the area tribal communities, a study was done where all the around 70% villages were suffering from bronchial diseases. Once they have health factors, their livelihood becomes problematic. They cannot work to live. And that's one factor is health. Basically, then second factor is the water. The clean water drinking is another crisis. The fluorosis, 2 districts of Madhya Pradesh, Shivpur and Dhar, where you have 2 different indigenous community living, tribal community. One is like Saharia, a particularly tribal group. Another is the Bhil and Bhilalas living in Dhar. The water is contaminated with fluoride content, and the fluorosis problem is there, and the children's and other things, they suffer this. So a good human being and a good community and healthy society becomes a problem. And with the change of climate, availability of water, the quality of water, they become another crisis which impact further. If you go to Badwani, where water table has reduced, another district of if you see on the patterns of ranking of development index, Badwani in Madhya Pradesh is 47th or 48th ranked district out of 51. And the water is around 700 feet. So getting access to water and all those things, with the climate variability, they become very challenging. So they are an aspect of it. Tribal health has been impacted. When you talk about public health, that reaching to tribal areas for the support is one big challenge, because they are the very remote districts on the parameters of access to health, taking the health centers, PhD centers, making them updated is areas where it's still lacking. And that's why they depend on the local traditional healers and the traditional patterns of living, which is very important, because health problems have to be addressed. And one thing is there which tribals need to understand about, we need to understand about the health, how tribals see. They don't see as a biomedical illness only. They see it as psychological and spiritual loss also. Like when I was working in the Eastern Madhya Pradesh on the sacred groves, a loss of sacred groves impacts their religious belief system, and it makes them vulnerable to the sickness. So that's one area where we could see. So basically, when we are trying to talk about these communities, so we have a huge gradient of communities where you can say variation. If you go by the poverty parameters, if you try to see that there is another 25% of population which is poor, and they basically belong to this indigenous communities, and their poverty is a challenge. And climate changes impacts them more, and it still brings them many crises to them. And lastly, I come to the well-being. When we're trying to understand the well-being, there are two: one subjective and the objective. The subjective is the psychological well-being of happiness and satisfaction. With the changing temperature and precipitation, this varies. But objective is the capability and activity. Because of the impacting health and lack of the institutional facilities, there is a problem of capability to do the work. So if the illness in the tribal is more, sickness in tribal is more, their capability and livelihood will become a big challenge. So that's what I could say. Lastly, I come to the community-based approach where we can do, if we want to understand and bring solutions to climate change and impact of it, we need to understand community. One is by place-based, because they are living in it, a tribes living in the coastal area, a tribe living in an island area, a tribe living into a desert area. There is a very different context, and the vulnerability of climate will be very different to them. So we need to get solutions and decisions which are common to those to be done there. Secondly is the pathway. What kind of livelihood activity you have adopted to that? Like pastoral communities, they can move around there. If I come across the Maldharis, if you talk about those who traversing from Rajasthan to the down to the Maharashtra and Madhya Pradesh, they cut across various ecosystem sectors. But those who are along the coast areas, there is a crisis of rising sea, there is a crisis of cyclone, there is a crisis of other things. So so two approaches. One is a place-based approach, another is pathway approach. Public health system should reaching to them, should try to follow this to what kind of places they are living and what is agroclimatic zone and what are the vulnerabilities to that. And changing to that, we need to find solution and activities which are there, like even the communities engaged into agriculture, living around the forest, they are into exposed to this man-animal conflicts. Another area with the changing climate, animals are moving out, moving to agriculture area. So there is a conflict be created, loss of habitats. In Chhattisgarh, I have seen elephants are moving to agriculture plains of tribal areas, and then conflict is there. So a whole complex scenario is generating. So I conclude with this: the community diversity in India is there. Another aspect which was there, if we go the intra and inter household, the vulnerability is very important aspect. In gender aspect, the woman is more vulnerable in the within the community, and the children are another layer where they are become vulnerable into that. So we need to be taking care among the women's health. In Madhya Pradesh, I have seen some kind of government policies help them into through institutional mechanisms. Some better healthcare facilities has come. Many states are taking up similar measures, but integrating this environmental factors into the health has not taken place. Even government planning, I am not seeing that much environment and climate change has become an element of planning. It's still at the debate level. It has not penetrated into the policy making, and it is again big debate where health has to come there. So this is a brief I would like to just was sharing with you, Manjeet, and look forward to further discussion on it.
Thank you so much. You have really covered a lot of ground small period of time, right from talking about vulnerabilities in particular area, even talking about the governance mechanisms as well, and about decentralized planning and how environment and climate change are not being kind of so range of topics. And I think it's always kind of but I think what I would like to certainly pick upon deliberation is on the vulnerability aspect, and that's what kind of connects to my next speakers, set of speakers. And we have Dr. Meena Sehgal and Dr. Nitish Dogra, who are from TERI and IHMR respectively. So I think in order to kind of have a targeted public health intervention, it becomes very necessary to understand the problem of the area, whether what kind of, we have talked about fluorosis, we have talked about drinking water issues, we have talked about other issues. First step in that particular direction is the vulnerability assessments, which are kind of carried out in order to assess the vulnerability towards climate change. So Dr. Meena, I would like you to first kind of pitch in on this, and then I would also like to have a response from Nitish after that. So can you please share your experience as Terry and as Aichimar conducting the vulnerability assessments, and how they are kind of useful to understand the interventions and kind of know the effectiveness of those interventions. So over to you, Dr. Meena, first.
Thanks, Manjeet, and thanks for the organizers. I think it's a good debate that we've started and good discussion which is going on, and with a wide outreach also. The way Terry has looked at it is a quantitative approach, and I think Nitish would very well add to it, complement it with his qualitative work also. The issues have been laid out by the previous two speakers very succinctly. They've told that there are diseases which are different, rather a large number of diseases are existing which are related to climate factors, climate challenges. And over and above, the distribution of these diseases is different in different areas. So some in the east are prone to cyclones. Another could be hilly areas which are getting more prone to malaria or vector-borne diseases. Then there is nutrition related stresses also in the community, poor trends of nutrition. Then you heard the second speaker talk about what the infrastructure availabilities are, what the opportunities are, what the gaps are in those. So if it's a tribal community, they don't have the same kind of infrastructure that other people may have. So all these conditions, along with the variability, have to be integrated into the policy making. So that's the challenge, that there are so many multiple factors. How do you integrate all these factors? So within a state also, if you look, there are extreme conditions between states. Definitely, people are aware of that. Certain states like Rajasthan, Uttar Pradesh, Madhya Pradesh, they have high stunting and undernutrition. Whereas Goa, Kashmir, northeastern states are better off. Nearly half the prevalence of nutrition-related problems. Similarly, states have a difference in number of healthcare workers or health providers that are available. So a place like Kerala may be endowed with around 30 per 10,000 of healthcare providers, and but Himachal may have much less. Bihar may have something like 1 or 2 people per 10,000 population. So whatever are the reasons of it, we want to make a landscape of what can be done. How do we differentiate these places? How do we show it to the policymakers what differences lie? So the approach in climate change people have adopted is that they integrate all these variables into 3 different domains. One is exposure related indicators, which Dr. Harshal also alluded to, that there is air pollution in Delhi. But air pollution may not be a challenge in, let's say, Panchkula. Then there are there's a high probability of drought, let's say in parts of Maharashtra, Marathwada region, or in parts of Andhra Pradesh. We people sitting in Delhi don't even come to know most of that agony that people go through. So these exposure indicators, which are like temperature, precipitation, ocean level rise, saline water intrusion, or any other weather-related effects like floods, droughts, cyclones. These are all clubbed together and called as exposure indicators. Then there are indicators which we also talked about, malnutrition, stunting, and there are issues about infrastructure, things like sanitation, water availability, the diarrhea-related indicators are also there. Some of these are integrated into and called sensitivity indicators. So like for COVID, you've heard senior people are more prone to getting higher risk factors or more severe form of COVID rather than the younger population. So those demographic variables are also very important. So then there was some discussion about how tribal populations may not personally have the wherewithals to handle any situation. So those are economic indicators. So between nutrition related indicators, socio-economic, demographic indicators, all of them are clubbed into a sensitivity domain within the vulnerability assessment task. Then the previous speakers also talked about how access to healthcare is different. And I also shared with you some numbers of how it is different between Bihar and Kerala, how people will be affected by any disease, whether it is COVID or whether it is climate associated effect. And these infrastructures could even include information technologies like TV, radio, availability of a smartphone these days, access to digital technology nowadays. So all those are packed together into a domain which is called adaptive capacity. So now we have three domains: exposure of the people, that is meteorology or weather variables; sensitivity of the people, that is age or their nutrition status or immunity status; adaptive capacity, which is how much can they stretch because of the availability of health infrastructure. So all three collectively form a vulnerability index. So we can use sophisticated statistical methodologies and enter all this data for each unit of area. That unit of area could be a state, it could be a district. So Terry has undertaken this task for at a district level. We've created a tool where the users are followed and the tool generates the index. First, it does give you exposure indicator domain-based ranking. It gives you a ranking for sensitivity, and it gives you a ranking for adaptive capacity. What that means is, in the case of Andhra Pradesh, there are 13 districts. So all 13 districts could get ranked from 1 to 10. And the system would also give you which is most critical variable in it. Which variable should you impact so that there's the largest benefit for, a bang for your buck. So those are also get popped up because we are following a very statistical approach, and its principal component analysis all available in public domain, and supporting literature is also there. Then using all these three indicators, the ranking for vulnerability assessment is done for the districts. And how does that help? Well, if I know there are 736 districts in the country right now, and I'm ranking 700 on a particular domain, exposure domain. So you can make a case for it. You can make a case to the policymaker, or district officer can make a case to its state level officials, and authorities can take action. And since we are also pointing out to which particular specific indicator is the most relevant or most critical to make a change in your ranking, to go from 700 to 70, let's say, one being the best. So those dimensions are also coming out. We are integrating what the previous speakers have said, that all these are going to make an effect on the health. How health gets resources, how targeted approaches can be developed, how accelerated responses can be created. Those are such tools can give you those directions. You can see the trend and then make your decisions. Apart from that, a vulnerability ranking can be done on for different regions across, so it can be done for the whole country. It can be done within agroclimatic zone. So maybe an agroclimatic zone has certain characteristics, and you want to kind of parameters or can be created for decision making. And that's one of the tasks is to really look for resources, make a scientific, create a scientific evidence based on lots and lots of data, and something which is comprehensible, because otherwise we are talking about infrastructure, exposures, air pollution, cyclones. And yeah, that also brings to mind one issue, that these indicators will not be same for all the regions. So what is critical for Prakasham, let's say, is not critical for Vishakhapatnam. Vishakhapatnam is a coastal district. It needs to worry about the saline water or the cyclone coming its way, and not about drought. So you can choose your variables, your parameters, which go into the vulnerability assessment based on your area's challenges. And I would let Nitish elaborate on this, because he's done some good work in Mewat and other places. And there are some other approaches also. Ours is so far has been very statistical. It doesn't include in it what the stories of the people are, what is the felt experience of the people. Like I, living in Delhi, know what it means to be in Delhi in November when it is hazardous level of pollution. People living in a cyclone area know what it really means. What is the mental trauma they go through when there's a cyclone outside, how it disrupts their life. So those quantitative, experiences, qualitative experiences have to be integrated in some ways. So I'll let Nitish talk about those and suggest ways of how to integrate those also in the methodology. So that's something which is very valuable. So thank you, Manjeet.
Thank you, Dr. Meena. And just to point out here, in case to all the speakers, Dr. Meena, your voice was little breaking in between. I think it was getting a little difficult to hear, but no problems. We're all facing that. So in between, if it goes like this, you can also switch off your videos just to save some bandwidth. So just a point to kind of help us remember. But Dr. Nitish, over to you now for your experience on the vulnerability assessments. Yeah.
Thank you, Manjeet, and it was really nice to hear our other distinguished speakers. Wonderful to hear from Harshal and Meena, and also our speaker who spoke so wonderfully about the vulnerability groups, but particularly the tribals who we somehow miss out when we are discussing in our usual discourse. So I think it's a really good background for us to build. So what I'd like to point out, so the International Institute of Health Management Research, IHMR Delhi, where I'm based, we got supported by WHO CRO to conduct the first detailed vulnerability assessment for climate and health. And this was an exercise. This was part of the 2010 Costa Rica consultation, and this was a common protocol for 16 countries. Now, in this, what emerged from these deliberations was a WHO guide. That was the first guide in the world for vulnerability and assessment for climate and health. And then we undertook the 2011 exercise for Haryana state. Now, again, we also follow a quantitative approach. Only thing is that our approach is relatively simple because it takes into account the inputs from the stakeholders on the ground and the experts. So, first experts, then talk to the stakeholders, and we get their assessments on the various indicators and the respective weightage. We follow the standard Human Development Index sort of methodology. And as Meena explained, we have all these indicators into these three categories of exposure, sensitivity, and adaptive capacity. These can be done relatively rapidly and requires minimum hand-holding, and you have a static sort of result. You don't have anything dynamic because that would obviously require a tool, which Meena is mentioning. So that is something which is the next level. That is what our approach is all about. And when we develop these sort of vulnerability indices, both this approach and the principal component analysis approach and several others, whichever approach you follow, you ultimately come up with a vulnerability index. the point here is that the vulnerability index, which we have over time and over various forums tried to emphasize, the concept of vulnerability is quite different from the concept of prevalence. So we have an inherent notion in public health and associated fields that wherever a disease cases are more, that is where the vulnerability of a place lies. And what we have demonstrated through this study very clearly is that this may not necessarily be true. This may be true, but this is not necessarily true. So we found, for example, in the district of Mewat in Haryana, the study was done in Haryana. So we found in Mewat that for malaria, for example, the prevalence was medium, but the vulnerability was very high. And that was because the community was not reporting to the health facilities. And so as a result, you did not have that many cases and that much prevalence. The vulnerability index, also taking into account community factors, is able to more effectively capture the actual prevalence, the community prevalence, and it is a very cost-effective method. So that's one of the sort of bonuses that you have with a vulnerability index. The second aspect is that we, again, in our planning, whenever we the district level planning, for example, it's a kind of notion that say there's a district which is which is aspirational, say. So in our second study, which we took up again with support from WHO India this time, in Rajasthan. So one of the districts, for example, Karauli, which is right next to MP border. So it was an aspirational district, but from the vulnerability aspects, climate vulnerability aspect, overall from this index that Meena spoke about, it was not a vulnerable district. So it's just because there is it's got some kind of challenge in as far as the development aspect is concerned, doesn't necessarily make it vulnerable from the climate perspective. So from the climate vulnerability index perspective, and vice versa. So that's how getting the climate perspective and changes your priority, and that's very important when we are talking about resource allocation. And lastly, you see, this is not really just something for climate sensitive diseases. Today, let's say for COVID, we are not so sure about the climate aspects, but the vulnerability aspect, leaving aside that, like Meena said about people in the elderly age category or whatever. So there are ways in which one can rapidly come out with vulnerability assessments which define how COVID, for example, is going to impact our community. It may not really give you a determinant of how it is going to affect the hospital per se or health system, but it will tell you about how it is affecting our community, because it takes into account things like socioeconomic factors, education, technology, things like that. So I think vulnerability assessments are really not just essential for the climate aspects, but also it should be taken into other aspects. Like, for example, tuberculosis, for long, we have done these sort of assessments, So these are definitely something that should be mainstreamed in general in public health. So I think this is the question that you had, the first question, Manjeet, and then I think there's a second question or whatever. You're the boss.
No, boss, you guys are the boss. I'm just trying to learn from experiences. So, but great, Nitish. I think you touched upon the right points and shared the experience of doing those vulnerability assessments. And both Dr. Meena and yourself, we have touched about the vulnerability index and kind of how to derive and what are the kind of major parameters how to derive this. and kind of both on the quantitative aspects as well as on the qualitative aspects as well. So thank you very much. Now let me kind of bring out here, and we all know that yes, in terms of climate change, government of India has been. I'm hearing that my voice is not audible. Am I being audible to most of you?
Yeah, you're audible.
I can hear you, Manjit.
Yeah. Okay. So government of India has been kind of very proactive in moving towards in its approach towards climate change, and we have seen that we have had the National Plan on Climate Change way back in 2008 itself, when it was launched with some kind of submissions, and so has been the Ministry of Health as well, kind of followed up and set up various steering committees and Avinash, Dr. Avinash Sunthlia from the National Center for Disease Control. Actions have been taken up to help in preparing for the health of climate change. And on that, Avinash, please.
Dr. Avinash, I think you're muted. No problem.
I'm sorry.
Wait,
So before I begin, I would like to congratulate the Sphere India for having such a wonderful session, and all the bodies who are supporting it, be it the WHO India or the UNICEF or the HCL Foundation. So see, climate change in human health, it is the topic of the day. And
Dr. Avinash, we can't hear you. You're muted.
yes. I'm sorry. Some network problem. So, climate change in human health is the topic of the day, and India has done some wonderful work on this. And in around 2008, we had our national plan for climate change in human health. After that, Prime Minister Modi in 2014 had committed in COP21 about starting a national action plan for climate change and human health. So we had this health mission incorporated into our policy and planning. So we have been working on climate change and human health since 2014. And with respect to the Sustainable Development Goals, the goal number 13, which says that the member states have to take urgent action to combat climate change and its impact. So it obviously highlights the importance of the topic that we are discussing about. So COP21 under the lot of work has been done by United Nations with respect to the United Nations Framework Convention on Climate Change and the Kyoto Protocol in 1997. So COP21 was there in Paris, and then we had this origin of climate change and human health program for the country. And the main focus is to mitigate the health-related aspects of climate change through a multi-pronged strategy. And I would like to tell here that we had this Mali Declaration in 2017. So India was working on this climate change and human health well before the other countries were looked into. So that is this shows the foresightedness of the government. We had made the National Expert Group on Climate Change and Human Health in 2015, and the various members who were involved, it was obviously a multi-sectoral committee which had members from the Health Ministry, then the Environment Ministry, ICMR, the Department of Science and Technology, then the NDMA, then Ministry of Agriculture, Ministry of Drinking Water and Sanitation. So obviously, to name all the people were taken on board, and we had discussions
to prepare an action plan. So how are we going to go about this program, and recommend strategies for adaptation, and obviously capacity building of the health system. So after that, the National Program for Climate Change and Human Health took shape. One of the key of the program is that this is very region specific, state specific. Like as our speakers have already told, that different areas of the country have different issues. Like say the problem of salinity in Visakhapatnam there is a problem of water salinity in Visakhapatnam. But then we have the issue of cyclone. Now cyclone is there in Gujarat and Maharashtra. Then there are areas which are vulnerable to low water. The water bed is low in those areas. So every area is then the speakers have talked about the emergence of the vector-borne diseases in certain areas where they were not found. So every area has got its own vulnerability and its own. I will not call it vulnerability. I will call it uniqueness in with respect to the opportunities. I should vulnerability. Okay, that is there, but then that is a unique opportunity. Every area has got its own opportunity where we can explore and make things work out. So we are very state. We are very we in our program. This program penetrates right up to the village level, and we have planning in such a way that the district, the block, at the level of the block. The block is something which is at the population of 1 lakh. 80,000 to 1 lakh, and then we have a CHC at the population 30,000. So those people, the grassroots people, are involved in the program, and then they plan according to their vulnerabilities or according to the diseases which are common in those areas, and then the block action plan and the district action plan takes the shape. After that, we have we combine the action plans of all the districts, and then the state action plan is formed. So this is the way we work out. Now, what is the goal of what is the vision of the program or the goal of the program? Basically, our idea is to have to build a climate resilient healthcare system in the country. So the National Program for Climate Change and Human Health, it works to build a climate resilient healthcare system in the country, and there are various ways in which we do it. If I talk about the main objectives, or I would call main pillars of the program, first of all is to raise awareness amongst the general population, the vulnerable population, and the healthcare workers about the issue of climate change, because this is a topic which we read often, but then what is it and how we have to go about doing things, how do we mitigate and how do we plan? So we need to raise awareness first. Then to strengthen the health preparedness and response system of our health system. So this is another objective of the program. Third one is capacity building of the healthcare workers, of the policymakers, and obviously the local workers who are working at the ground level in the local areas. Then to develop partnerships among lot of organizations are working in the field of climate change. The idea of the government is to bring on board all the organizations, non-governmental organizations, obviously governmental organizations are all there in our committees, all the non-governmental organizations, to bring them on board and to say learn from them, or to share in I would use the word share the experiences of the NGOs who are working in the field of climate change, and to through inter exchange of ideas, through the exchange of ideas, we move forward, because at the end of the day, our goal is to have a climate resilient system in place. And the last component of the last objective I would say of the program, which I would like, this is the most key aspect of the program. That is to strengthen the research capacity. So we have to continuously undertake research which should be localized. I always advocate, we always have, we should approach every issue, every area. India is a diverse country. It has uh, 22 scheduled languages and so many unscheduled languages are there. Then we have so many communities which runs into thousands. It is a 5,000-year-old civilization. So I would like to, I think of it as a uniqueness in itself, because if we have to take such a big country with vast geographical expansion, climatic conditions, the resources, the literacy levels of the people are there. So all these things are a beauty of a 5,000-year-old civilization, and we have to take, we have to keep all people on board. We have to think of aspirations of every segment of the society, and then we have to understand the unique apprehensions, or you can say unique issues of every segment of the society, and then we should be moving forward. So here in this aspect only, in this regard, the research capacity is very important. Like, we should understand the gaps with respect to the local areas, and we should have localized plan of action for indigenous solutions. For indigenous solutions, I will repeat, we need, for indigenous problems, I'll for indigenous problems, we should have indigenous solutions. If we have indigenous solutions, then we are not copying somebody else. And if we are and for indigenous solutions, we need local research. So we need to strengthen the research capacity up till the level of the village, up till the level of the block, up till the level of the district. So all the research institutions which are there in the state, or the central research institutions which are involved, they should be they are on board with us, and we try to understand we try to understand region specific issues with respect to climate change and health. Now I come to the another aspect. Once I have explained the program to you, regarding how do we go about implementing the program. So I again and again I am telling one thing. बार बार मैं एक ही बात को जोर देने का प्रयास कर रहा हूँ कि हम लोग जो है लोकल रीजन पर जाके, जो गांव है, गांव स्तर पर जाके हम लोग इस प्रोग्राम को लाना. I want to be bilingual because there most of the audience, I think they will be able to comprehend it properly. तो हमें गांव स्तर पर जाके इस कार्यक्रम को हम लोग चलाना चाहते हैं और चला रहे हैं, जिस वजह से हम इसमें जो हमारे गोल्स और ऑब्जेक्टिव्स हैं हम उनको अचीव कर पाए. तो हाउ डू वी गो अबाउट डूइंग इट? हमारा एक ऑर्गेनाइजेशन स्ट्रक्चर है. वी हैव बॉडीज एट द नेशनल लेवल. नेशनल एनवायरमेंटल हेल्थ सेल वी हैव अंडर द मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर. उसके बाद हमारे स्टेट लेवल पर होता है, जिसके अंदर स्टेट लेवल पर हमारी स्टेट गवर्निंग बॉडी होती है. उसके बाद स्टेट एनवायरमेंटल हेल्थ सेल होता है और बाकी टीम के मेंबर्स होते हैं. उसके अंदर सारे मंत्रालय हमारे पास जो ऑन बोर्ड मेनली इन्वॉल्व हैं वो होते हैं. ड्रिंकिंग वाटर एंड सैनिटेशन होता है, मिनिस्ट्री ऑफ एग्रीकल्चर होता है, मिनिस्ट्री ऑफ एनर्जी है, लैंड वाटर लैंड रिसोर्सेज है, मिनिस्ट्री ऑफ रिन्यूएबल एनर्जी, मिनिस्ट्री ऑफ पावर, एवरीवन इज ऑन बोर्ड. मिनिस्ट्री ऑफ फाइनेंस इज आल्सो ऑन बोर्ड. तो ये सारी कमिटी हमारे पास होती है. वी कॉल इट एज द गवर्निंग बॉडी. देन आफ्टर दैट डिस्ट्रिक्ट लेवल पर हमारे पास होता है एनवायरमेंट. एक स्टेट पर एनवायरमेंटल हेल्थ सेल हो गया, हमारा डिस्ट्रिक्ट एनवायरमेंटल होता है. डिस्ट्रिक्ट लेवल पर डिफरेंट प्रोग्राम्स के ऑफिसर्स काम कर रहे होते हैं, वो इन्वॉल्व होते हैं. और उसके बाद हमारा ब्लॉक लेवल पर जो CHC होती है, वहां पर वी हैव अ ऑफिसर इंचार्ज फॉर द प्रोग्राम. और उसके बाद जो PHC होती है 30,000 की पॉपुलेशन, वहां पर हमारे जो PHC मेडिकल ऑफिसर है, ही इज इन्वॉल्व. और हमारे प्रोग्राम में हम लोग लोगों में जो मैंने सबसे पहले आपको बात बताई, अवेयरनेस की जो बात करी, तो जो PHC मेडिकल ऑफिसर है वो विलेज हेल्थ एंड न्यूट्रिशन सैनिटेशन कमिटी जो होती हैं, उसके अंदर हमारा क्लाइमेट चेंज भी डिस्कस किया जाता है। और ये हमारा प्रोग्राम 2015 से चल रहा है और हमारा एनएचएम के अंदर भी ये प्रोग्राम है। और इसके अंदर एनएचएम में प्रोग्राम आने की वजह से हम इसको और अच्छे से कार्यान्वित कर सकते हैं राज्यों के अंदर। इंटीग्रेशन में भी हमें इसमें लाभ मिलता है। एनीवेज, तो ये प्रोग्राम का हमारा स्ट्रक्चर है। मुख्य रूप से if I categorically want to state what are the diseases which we are looking after, that climate sensitive diseases काफी हैं, 15-16 diseases हैं। और इन सबके बारे में बातचीत सभी पैनलिस्ट ने करी है। जैसे वेक्टर बॉर्न डिजीज है, जूनोटिक डिजीज है, देन रेस्पिरेटरी डिजीजेस, कार्डियोवास्कुलर डिजीजेस, माल न्यूट्रिशन, because malnutrition, डॉक्टर हर्षल साल्वे ने बात करी malnutrition, how malnutrition is related to climate change। उसके बाद फूड बॉर्न डिजीज होती है, वाटर बॉर्न डिजीज होती है, एंड ऑफ कोर्स अभी हीट सीजन है। वी हैव बीन लकी इनफ कि अभी हीट तो इतनी आई नहीं है, मे बी बिकॉज क्लाइमेट मतलब सारी इंडस्ट्रीज वगैरह सब बंद थे, तो इतनी गर्मी पड़ी नहीं, हफ्ते भर गर्मी पड़ी थी, ज्यादा नहीं हुई। एंड ऑफ कोर्स एयर पोल्यूशन है। एयर पोल्यूशन में Delhi, तो everyone knows about it, public health emergency of international concern, it was declared last November। तो ये सारी चीजों के बारे में हम लोग we cater to so many different diseases, and with the common vision, क्योंकि सारे NGOs जो है इसी में काम कर रहे हैं। आपका भी विजन वही है, हमारा भी विजन वही है। हम लोग सब सारे स्टेक होल्डर्स जो भी इसमें इन्वॉल्व हैं, हम लोग सारे एक दूसरे के साथ मिलकर कार्य करेंगे। एंड आई थिंक वी विल ऑल अचीव, अपने जितने पार्टिसिपेंट्स हैं, पार्टिसिपेंट्स हमारे जो है 122 122 आर देयर। तो यही है कि ये अपना देश है और इट इज आवर विजन, सबका कॉमन विजन है कि देश को we should have a climate resilient healthcare system in place in the country, and we will all achieve it. Thank you.
Thank you, Dr. Avinash. I think you have touched upon very important points, and I really like that approach which you said from completely turning the whole vulnerability to an opportunity, and certainly there are opportunity to work in that particular area. And then you talked about the partnerships of the civil society, which becomes very, very important to kind of flag the issues and bring those issues. And then you also touched upon the interministerial coordination and how this whole national program on climate change and human health is kind of trying to forge that interministerial coordination, because again these are kind of cross-cutting issues. And then you also focused on the localized research. Your emphasis on the localized research was very, very important, as to if we really have to intervene, we need to have the evidence from that particular area to kind of help us allow to work further. So very important points. I think looking at the watch, we are running out of time. We have kind of taken some detailed discussion, but if I can just ask now a few of the panelists one or two kind of questions to just answer in just 2 to 3 sentences, and then I would like to have a question addressed to all of you to be answered very briefly and have your views on it. So let me kind of check with Dr. Harshal Salve. If you, Dr. Salve, very briefly talk about, we have been talking about climate change, how these connections of climate change are kind of with the virus outbreaks like COVID, and we have been kind of hearing about Ebola, we heard about Zika, we heard about Nipah, and now we are hearing about COVID. What are those kind of connections between climate change and these kind of regular virus outbreaks which are happening? Very kind of brief comments from your side.
Yeah, thank you, Manjeet, for a very pertinent question. So because we are in the COVID times, I will just briefly talk about what are the evidence available with respect to the COVID and the climate factors. So as far as if we go by the scientific evidence, so there is one paper published which talks about the relationship of COVID transmission, infection transmission, and the temperature. So COVID infection is inversely related with the transmission. That is, if temperature increased by 1 degree Fahrenheit, then there is a decrease in the cases of 6.4 cases per day. Similarly, with the precipitation, that is a rainfall, if there is an average increase in the inch per inch, 1 unit inch per day in rainfall, so there is an increase in the 56 cases per day. So there is a inverse relationship with the rainfall, particularly the infection, and there is a direct relationship with the temperature. This is only with the infection. As we know, the understanding and the science related to COVID is evolving over a period of time. So far, there is no relationship was found with the mortality, but we also need to consider the limitations of all these studies which is happening in the pandemic. All these are the ecological studies. So this is evidence. And as I mentioned previously, the communicable disease are properly linked with the climatic variables, and a lot of evidences are available. Thank you.
Thank you, Dr. Salve, for that very brief comment. And I think now, since you have already set the context for COVID as well, I want to kind of put this question to all the panelists, and starting maybe with you itself. I want to ask that. See, COVID, we have seen that somewhere we feel that there's a school of thought that COVID has pushed the climate action to the back burner as this public health crisis unfolds, and because there are fears of long-term economic recession which are kind of pressing. What are your views, just briefly? And but again, as what I think the speaker said, there's an opportunity to always turn around there for on the positive side. What would be, in your opinion, the prescription to build better from here? So just briefly on the views on the economic recession and on how to build better. Dr. Salve first.
Yeah, thank you, Dr. Manjeet. So as far as the impact of, because when we say the response to the pandemic, most of the country responded with the lockdown, be a complete lockdown or a partial lockdown. So I will say there are three sort of areas when we discuss the impact of lockdown and the climate change. So in the form of benefits, opportunities, and the threats. When we say the benefit with respect to the climate change, so obviously it is documented that in the month of April, there is a reduction in the carbon emission. Also in the form of preserving biodiversity, because there are less people on the road, less people everywhere. So in terms of your sort of augmented the preserving the biodiversity, and also at the most of the population where there is a population density, so there is a reduction in the
Dr. Salve, I don't think so. We are able to hear
surveillance,
you.
the health system.
Yeah.
Health system and health surveillance, because the data if you really want to document the impact of climate change on health, so health data is very important. So this COVID pandemic gives us opportunity and also tell the importance of the continuous surveillance of the health data. So this is the opportunity we have to strengthen our surveillance. Also, I think at the population level, people also got more sensitized toward this health, their behavior, their lifestyle. So I am hopeful that this will continue in the post-COVID era also. Coming to the threats, as you said rightly, due to the priority given to the COVID, handling COVID pandemic, the other diseases find in the back benches of the priorities. So there are chances of increase in the other morbidities, other communicable and the non-communicable diseases. And more importantly, the vulnerable. Because of the economic slowdown, the vulnerable has become more vulnerable, be it a migrant or be it a daily wage laborer. So vulnerability has to be seen when you plan the next actions in post-COVID area. Also in the reverse migration, you are seeing that the migration is happening at their hometown. So the states which are receiving the migrants now are now burdened with the care they have to give to all this increasing population. So my briefly 4 points how to move forward. So first thing is connecting the all stakeholders, because this pandemic response galvanized all stakeholders at the community level, national level, and at the state level, starting from NGOs, academicians, researchers to program implementers. So we need to build this connect throughout in our response. Invest in the surveillance. We need a robust surveillance with respect to communicable and also to non-communicable diseases to some extent. Build on the climate resilient infrastructure, as mentioned by Dr. Avinash. It is an inbuilt part of the national program. So we need to focus more on the climate resilient infrastructure, because in the situation of the extreme weather situation, or the health system which get impacted first, and that impacts the routine healthcare. Promoting the healthy lifestyle at the community level by community participation, and increase, as you say, there is an economic response given by the government. So we need to increase the social response in our social direction, social dimension, social programs, welfare programs more, because that will take care of the vulnerables who are being more affected during this lockdown period. Thank you, Dr. Manji.
Thank you, Dr. Salve. I quickly give the floor to Dr. Amitabh Pandey for his views on these two issues. Dr. Amitabh Pandey, please be brief on this. Is Dr. Pandey there? Can we get in the meantime Dr. Meena Saigal then?
Dr. Amitabh is there. I see him.
Okay,
Yes,
I'm here. Manjeet,
yes,
I just
Dr.
muted
Amitabh,
my.
please.
Sorry for that, because I was listening to you all. I have basically the one aspect of the impact of climate and the COVID, because now we need to see at least 1 year cycle, what is happening with the climate and all that. The two aspects which doctor has said it, one is about the temperature and one about the rain, and we need to see any correlation is there or not. What I could see, basically the community resilience has increased with this kind of fight back approach by the community and by the individuals. That is one change I am seeing. Change in social capital I am seeing. Reduction in consumerism I'm seeing that there will be a different pattern in the consumerism which is happening around, and that will be there. Yes, certain industries will be affected, but I can see there will one more aspect is that rural economy will make a big change, because those who have migrated down to villages, they might start working and contributing to the rural economy. Another thing which I foresee is the federal system strengthening, which is happening because if each state is now fighting the public health problem itself, rather than center doing the main part. So the improvement in the state government governance that's happening. Another area which I see is that basically the exchange of labor through federalism may happen, because you could see some chief minister was already saying that now they will negotiate with the other state when they send the labor. So there are many things which this disease has brought around. But one I could say is the community's resilience is improving, and that will help us, because with all the statistics happening, I could see the community fight back is happening.
Thank you so much, Dr. Pandey, for your very brief comments and very pertinent comments out here. Dr. Meena, can you come in now?
Yes, sure, Manjeet. Let me know if you don't hear me well, but
You're audible now.
I agree with the two. Okay, good. I agree with the two speakers. There has been several positive changes, and the trend is the only thing we wish is that the trend continues beyond COVID also. And the biggest changes I would like to see become strengthened are access to healthcare, whether it is through digital platforms or through virtual healthcare. That would bring a lot of equity within the population, whether it is a urban population with slum dwellers or whether it is rural population who has very poor healthcare provider ratio to population. So if those things get strengthened, that would be a good outcome of this experience. Another is that being from Delhi, what we have witnessed within 5 days, the ambient air quality improved. The PM levels, the particulate matter level was within ambient air quality standards of the country. So they were less than 60, whereas typically they are always in 160. So dropping them by that level, or even if they were brought down by 50% most of the days, it was an eye-opener for everybody. And things that had changed were the local transport was not working. People were probably still using the biomass fuels, those households who use it, even in neighborhoods of Delhi. So that's a message to all policymakers that if we transition from the current fuel patterns to cleaner methodologies, whether in industry, whether in transport, whether we promote a public transport or go towards e-vehicles, all those measures are going to make visible changes. This was COVID is a very expensive learning all about air quality, but it still teaches us a lesson that we can be a bit lax in doing certain things, and more aggressive action can be taken to improve air quality, whether it's through air pollution controls or GHG emission controls, or moving to different agricultural patterns, increasing sustainable agriculture in the country. So those are my points.
Thank you, Dr. Meena, for your comments. Dr. Nitish.
Thank you, Manjeet. So I would just like to say, I don't want to, repeat what others have done, and also we are just short of time. But one point I would just like to highlight. Dr. Harshal spoke about involving stakeholders. Now, you see, what we have here is basically right now the COVID situation. It's a biological disaster, right? Now, along with the biological disaster, we also happen to have the climate disasters going on, and which will continue beyond COVID also. We know that, right? So, not only do we have to have the preparation for the climate disasters, that is must, there's no doubt, but we also have to have a systemic response where the disaster community is working closely with the health community, and the same principles which are taught, right? I'm not saying they are not taught. The entire country, all the main medical officers and right down to districts and even lower, they have been already trained. But now when we are seeing the disaster unfolding and we are seeing how various states are responding, etc., I'm not trying to highlight any one state or the center or whatever, but I'm saying that, the translation of the principles of disaster management to within the health sector are somewhere lacking. The training is there, but the when it comes to the SOPs, the actual work on the ground, there are huge disconnects, right? So I think this approach, if we have in place for the climate disasters, they will be useful for biological disasters, will be useful in general, right? And this stakeholder aspect that is so important in climate is also something which is going to yield dividends for the health sector when we are dealing with larger problems. So climate is just one amongst them. So basically that health system strengthening, and for example, this one point that Dr. Harshal mentioned about, linking with the environmental variables. Now, this is actually not so difficult, because it's the environmental the variables are already very well done by IMD for over 100 years. So that database is out there. We have an entire system of surveillance which is there by the IDSP and the related departments, related organizations. Now the question is that, over the last 10 years, practically now we have been struggling to put the two data sets together, which can enable us to have early warning systems in place, which can really help. So there is research going on. We ourselves, IIT, AIIMS and IHMR are working on one such project. But, if there is a policy level thrust on this particular issue, it is going to yield dividends which have been documented in other countries as 10 times greater than the investment. And that is where we need to go very urgently. That's the one point that I'd like to make.
Thank you, Dr. Nitish. Dr. Avinash, if you can comment on these 2 points very briefly.
Yeah, thank you, Manjeet. Thank you. I think I'm audible.
Yes, you are audible.
Hello. Yeah. I would like to add to what Dr. Nitish Dogra is telling. We were discussing about the healthcare workers, the translation of the guidelines into the practical field. What I want to say is, it usually happens when we are formulating guidelines. So we formulate them in such a way that they are the ideal, right? So they will be totally perfect. But when we go about teaching the same thing to the people in the field, usually what happens, if you tell them 10 things, they will be learning only 3 or 4. That is human, right? That is why when we used to study in our schools, we used to have pass percentage only as 33%. You get 33%, you are passed. You're not passed when you get 100%, right? So uh, we should have patience we should show patience during implementation of a program with respect to the fact that how fast are we going to achieve our objective. So we have all the relevant guidelines with this. So uh, um, uh, there we are training people on the field. They are getting trained. Climate change is a new topic, and yes, forget about climate change. The existing RCH programs or immunization programs, if we tell them certain vaccine protocols that they have to keep vaccines in certain way, people do mistake things. So we have to show patience where human is involved. Right? Secondly, this is a general. Okay, now one general statement. What I want to say is, uh, see, we are a 5,000, and I always say this everywhere. We are a 5,000-year-old civilization, right? We are a 5,000-year-old country. Now, we should not, usually what happens, we compare ourselves with nations which are 300 years old or 400 years old. So that is not right. We have so many communities, we have so many languages, and so many countries inside us, right? If you see the population, every year a new Australia is added in the country, right? So we have such enormous diversity with respect to understanding. The people will not understand things what the government says. Then the government has to be specific to every particular race, every particular type of people, every particular region. So many things are there. जब हम लोग इतने सारे लोगों को साथ लेके चलते हैं, समस्याएं होती हैं। तो ऐसी बात नहीं है कि हम लोग उसमें कार्य करना छोड़ दें या हम उस चीज पर ऐसे ना करें। तो हमारी अपनी संभावनाएं हैं, बहुत सारी हमारी, we have our own unique opportunities, and I think we should all the challenges should be seen as unique opportunity. और अभी ये जो कोविड की अपॉर्चुनिटी आई है, इसमें what we need to do forward, कि जो हमारा पब्लिक हेल्थ स्ट्रक्चर है, दैट इज ऑलरेडी इन प्लेस, बट इसमें एक लोगों के अंदर विश्वास हुआ है, पॉलिसी मेकर्स में एक विश्वास हुआ है कि जो पब्लिक हेल्थ है ये एक बहुत बड़ी चीज है, ये हमारे पास होनी चाहिए, ये इसकी आवश्यकता हमको है। So we should go about strengthening the public health approaches within the government and outside, and this will go a long way in achieving our objectives. So, any other question? If anyone has to ask.
Thank you so much, Dr. Avinash, for these brief comments. And I think I'll not take much time to sum up, but I'll just kind of very briefly mention the points which all of you have said. So certainly the opportunity here is to strengthen the federal structure and strengthen the public health system, as speakers kind of pointed out. We all are indicating towards moving towards sustainable consumption. I think this word has kind of redefined its meaning, and now we have most of us have understood it very kind of differently in the last few months, what we have seen. So the lifestyles would certainly kind of be changed. The resilience is going to increase. We have faced tough time. The resilience
I don't think I can hear. Can anybody else hear?
I think I'm back. So this is going on and off. So
Okay.
sorry for that. So what I was talking about is on the resilience aspect, and then we kind of also heard in terms of the access to healthcare and things like digital healthcare would be becoming much more important. So so these are the kind of points which we would be is the description for better. So I think let me now, we have exceeded our time, allotted time, but the session would not be complete if we don't kind of allow one or two questions. So if the host agree, can we take up like two questions from the participants?
Yes, no issue.
Great. Thank you. Manjeet, should I go ahead and unmute some participants who have been raising their hands?
Yes, please. Yes, please.
Great.
Two questions, please.
Right.
Yeah.
So we have a raised hand from Dr. D.S. Rawat. Dr. D.S. Rawat, hello. Dr. D.S. Rawat, I'm trying to unmute you. If you could just like accept that.
Yeah. I'm Dr. D.S. Rawat. I've got to. I've got if you see the national health accounts for India 2019 and 1920, I have seen a lot of money is given to the NRHM. There's a proper distribution system in there, and a lot of I was very much impressed with Avinash Sunthlia and other speakers there. And if you see the NRHM, their distribution of the money is not properly on the rural healthcare system. And if you want to make the climate resilient healthcare system, we have to have, our most of the SADs, PSCs are vacant. So then we have to have, medical research and health services together. We have to invite the research so that they can work in the remote areas, and we can enhance these facilities of healthcare delivery in the rural area, and we can take a digital platform to improve our healthcare facilities in rural areas. So this is my submission to your great scholar, and I feel that you will take up this issue of post-COVID. We have to have some digital platform more stronger and making the people climate resilient and our infrastructure climate resilient. Thank you very much.
Thank you, Dr. D.S. Rawat. I feel that was a really nice.
मैं कमेंट करना चाहता हूँ अविनाश मैम आई वांट टू स्पीक
Yes,
हाँ हाँ सर आपने ये प्रश्न पूछा आप हमारे कार्यक्रम में यू हैव पार्टिसिपेटेड इन आवर प्रोग्राम थैंक यू सो मच फॉर दैट पहली बात दूसरी बात आपने प्रश्न पूछा इसके लिए धन्यवाद आपको जान के यू विल बी वेरी हैप्पी टू नो दैट NHM द नेशनल हेल्थ मिशन is one of the largest health programs in the entire world और इसकी सबसे अच्छी खूबी है 66% of the budget 66% of the budget of the national health mission it goes to primary care 66%
Dr. Avinash.
yes, 66% budget of the NHM it goes to primary healthcare तो ये चीज मैं आपके संज्ञान में लाना चाहता हूँ दूसरी बात आपने ये बोली कि IT इनेबल्ड चीजें हमें करनी चाहिए हमारे पास इंटीग्रेटेड डिजीज सर्वेलेंस सिस्टम है IDSP का प्रोग्राम है 2004-5 से चल रहा है और इन IT के लिए अलग-अलग तरीके से हम लोगों ने अपग्रेड करने की कोशिश करी है अभी रिसेंट में IHIP आया है और हम लोग लगातार IT के ऊपर जो है हमारी कैपेबिलिटीज को स्ट्रेंथन करते रहते हैं तो सर आपके जो प्रश्न है उसका जवाब मैं ये देना चाहता हूँ कि सरकार के संज्ञान में ये सारी चीजें हैं और हम लोग इसको कर रहे हैं
नहीं संज्ञान में है लेकिन they are practically it is not available in the market ground I belong to a Fortune 500 company ONGC I am super innovative and I have seen the healthcare sector and second I have seen that rural area. I belong to the rural area and that too from the tribal area and I have traveled across India and I have done so many corporate social responsibility through my organization It is the number one organization
देखिए
doing
सर,
so
मैं
good.
आपको बताऊं सर एक बात बताऊं, कुछ
Dr.
अनुभवों
मैं
के
आपको
आधार पर मैं आपकी बात
Dr. Avinash and Dr. Rawat,
Yeah.
Dr.
मैं
Avinash
आपकी
and
बातों
Dr.
को
Rawat,
Yeah.
can we, so
कुछ
Dr.
अनुभवों
Rawat,
के
your
आधार
point,
पर हम लोग
Dr.
कुछ
Rawat,
अनुभवों
your
के आधार
point,
पर हम पूरे हेल्थ सिस्टम को नहीं बता सकते, पूरे
that's
हेल्थ
true.
सिस्टम
You
को
are.
नहीं बता सकते। आपकी बात बिल्कुल सही है।
My video should be on.
हेल्थ इज अ स्टेट सब्जेक्ट, हेल्थ हेल्थ इज अ स्टेट सब्जेक्ट, हेल्थ इज अ
That's
स्टेट
true.
सब्जेक्ट। तो
That's why
आप
I
जिस
am.
राज्य से बिलोंग करते हैं, उस राज्य के अंदर हो सकता है समस्या हुई हो, कुछ इलाकों में समस्या हुई हो, अच्छी बात है, उसके लिए निरंतर
आसाम में
कार्य
भी
किया जा रहा है।
मैंने आसाम में भी देखा
हाँ
है.
जी, हाँ जी।
can
I
we,
was there in
हाँ
Assam.
हाँ,
I got
असम में मैं
better.
आपको बता दूं, नॉर्थ ईस्ट में हमारा एनएचएम का 90% बजट जाता है। जी जी।
नहीं,
I
एक हमारी
request Dr. Rawat
एक
and Dr. Avinash, please to
Dr. Manjeet, whenever
not to
speak.
have Dr. Rawat, please can we kind of move forward in terms of, we have taken your
Please.
point, very valid point in terms of the research which you're talking about in the local areas, and I think what even
Yes,
Dr. talked about in his deliberation.
Very
You
right.
talked about the digital platform. These are very important points. We kind of take note of these points. So I think the direct
एक
issues
जम्मू
of
कश्मीर
particular
से
area
जावेद,
could be kind of taken up later. Can we get
हाँ
more
हाँ,
questions, please, sir?
Very nice.
Can
जावेद
we have some
जावेद
more
अहमद,
questions, please?
Thank you very
हाँ,
much. Thank you.
I'm sorry, I'm going to take the next
I
question now.
want to speak. One in the chat I can see Javed Ahmad Taq is there, a disability activist from J&K. So he has pointed out that what the program, the effects of hot climatic conditions increase in disability, awareness about increase in disability due to climate change needs to be discussed. Your point is well noted, Javed Ahmad Taq from Jammu and Kashmir. First of all, thank you for participating in the event. If you are listening to me, I would like to reply that in the vulnerable population, disability, those people who are specially abled, I don't call them disability, I call them specially abled. So they are being taken care of, and we have guidelines for them also. So that is in our consideration. And thank you for your participation.
Thank you, Dr. Avinash, for your comment. We're going to quickly take the last question from Dr. Sachin. Dr. Sachin, I'm going to unmute you now. Sir, if you could accept that request.
Hi, everybody.
Yes, you're on.
Yeah, good evening, everybody. This is Dr. Sachin Udaypurkar from Navi Mumbai. I'm an ex-student of ISM, alumnus of ISM. I'm a medical graduate from Government Medical College, Nagpur. So, in precise, this is about me. Besides, I have worked into the insurance sector since 2004. Coming back straight to my question, as far as the disability part, or I would say the health aspects, which again rightly pointed out, rightly conveyed just now, that it is a state subject, by Constitution of India, irrespective of anything, and the various global institutions coming into India as an assistance, or I would say increasing its, I would say, scope or show the direction. What is the efficacy of such mission or such programs at the ground level? Because now at the juncture when we say it is the eventuality that is called as COVID, which has made or which has increased the feelings or made them to think that health is primary or important. Fine. But what about already the missions which, or I would say the schemes those are running? What is the effectiveness of those already implemented? Are those validated? The point is, there is over there the gap wherein the awareness factor is very minimal, or no one is bothered about that aspect. That's what I could say. If that is made more stringent, it would be, yeah.
Sachin, sorry, I'll have to keep this brief. We've heard your question. I'm going to hand over to any of the faculty members who want to take this up.
Dr. Harshal. Dr. Harshal is raising his hand, so can he take this up?
You'll have to unmute yourself, Dr. Harshal. You're muted.
Sorry. Thank you, Dr. Sachin. You belong to my alma mater in GMC Nagpur. So it's great to connect. As you said regarding effectiveness implementation, so as said by Dr. Avinash also, we have variety of programs, more than 125 health programs we have, which are running more importantly in the rural area because we have more structured setup as far as the health system is concerned there. We are catching up in the urban area. Yes, that's one part. Yes, the COVID caused a lot of disruption in the health system because of the priorities of the government to tackle the pandemic. This has transiently suffered the existing health system because of the lockdown issues and other priorities. Our health task force is involved in the surveillance, which is surveillance activities. So I am hopeful that once we come into the end of this COVID pandemic, hopefully at the end of this year, so we're going to catch up with the health system, routine healthcare, which was being there. Now we are at the beginning of resuming our routine activities in the health system. Thank you.
Thank you, Dr. Harshal. I think that's all the time that we had for questions today. So, Manjeet, are there any more remarks from you?
No, I think we have already exceeded the time. So thank you very much to all the panelists and to all the participants to kind of know for this interesting discussion. And apologies that due to the paucity of time, we had to curtail this a little, but I think the points which the panelists have brought out here certainly need much more time for deliberation, and maybe they in future they could come up as a complete session in itself. So, and I think there we'll kind of get more opportunity to talk about this. So I think that's it from my side, and over to you, Valerie, if there are any kind of further comments, or we can kind of now end. So thank you very much.
Absolutely. Thank you, Manjeet. I completely agree that this requires much more deliberation and discussion because there were some comments in the box that we could not take. So hopefully in the future, we can have a more elaborate session on this. For now, I would like to thank all of our panelists and participants and our moderator again to be a part of this panel discussion. I would like to announce our third panel discussion for the World Environment Day week that we are celebrating. This one will be on air pollution and COVID-19 gearing up for the future at the same time tomorrow, which is 4 p.m. to 5:30 p.m. So please log in. For your certificate of participation for this particular panel discussion, please visit www.sphereindiacovid19academy.org. There will be a certificate button next to the name of this panel discussion, and you can download your certificate from there after entering your registered email ID. If there are any problems, if there are any comments, suggestions, anything at all, please feel free to write to us at covid19academy@sphereindia.org.in. A very special thank you to Glenda for being with us and helping us make this session more accessible. Thank you, everybody. Thank you, Dr. Amitabh, Dr. Nitesh, Dr. Harshal. Thank you, everybody who was here.
Thank you all. Thank you all.
Thank you. Thank you
very much. Thanks to Glenda for taking it much beyond. So thank you very much. Yeah.
Oh, great. All right. See you all. Have a safe
Thank you, Manjeet. Thank you all.
Thank you, sir. Thank you.